Good afternoon, everyone. My name is Kathy Ottenhoff, and I'm one of the Born coordinators. On behalf of Born Ontario, I would like to welcome you to our provincial rounds. We're very pleased today to have Kathy O'Grady-Venter presenting on the Baby Friendly Initiative in Ontario. We also have Doris Balcaris, who will speak to us about the BFI experience at the Grand River Hospital in Kitchener. Tammy Kipfer is also here. Tammy is another Born coordinator. She's in the GTA region, and she has a special interest in BFI. Tammy will have the pleasure of introducing you to our second speaker, Doris. So a few things to mention. There'll be time for questions at the end of the presentation. Please type your questions in the chat box. You can access the chat box at the bottom left-hand side of your screen. And as you have heard, these rounds are being recorded and will be posted to the Born Ontario website. I'd now like to introduce you to our first presenter, Kathy O'Grady-Venter. Kathy is a nurse midwife, an international board-certified lactation consultant, and a WHO UNICEF trained BFI assessor and trainer through the International Baby Food Action Network Africa. Kathy currently works as a lactation consultant in the breastfeeding clinic at Sunnybrook Health Sciences Centre in Toronto. In addition, she provides breastfeeding education and is a Baby Friendly Initiative consultant. She is co-author and facilitator of Making a Difference course and teaches this course in many Canadian provinces. Kathy chairs the Breastfeeding Committee for Canada, the National Authority for BFI in Canada, and is a BFI lead assessor. Volunteer activities also include extensive leadership in BFI Ontario, and her work was recognized by the Canadian Lactation Consultant Association, who granted her the Award for Clinical Excellence in 2010 and again in 2013. So welcome, Kathy, and I'll let you forward your slides there on the bottom right.
Thank you so much. It's a privilege to be here to talk to you today, ladies and gentlemen, if there are any. I have got so much in the slide presentation which I forwarded. I'm not going to cover each of the slides, but I wanted you to have the background for some context if you found it valuable. So to speak a little bit about the Baby Friendly Initiative Ontario to this group is really important to me because the work that Born has done particularly has furthered the efforts of the BFI. So I'm going to try to explore that a little bit as I go through the slides, and I will try my best to hurry up because I know Doris has really exciting stuff to share with you as well. So the thing about the Baby Friendly Initiative is that it's an international initiative, as you all know, a global initiative. World Health Organization and UNICEF launched it in 1991, and so it's been around an awfully long time. It is the only initiative launched by WHO UNICEF which is applicable to all countries, whether they are industrialized or developing, and has equal successes in both contexts. So in that it's unique. It is based on the principles of informed decision-making and best practice standards, and focuses on the continuum of care. And that is why we call it the Baby Friendly Hospital Initiative in Canada, not the Baby Friendly Hospital, right? It's the Baby Friendly Initiative, not the Baby Friendly Hospital Initiative here, because we wanted to stress the fact that it's not only hospitals that are responsible for putting in place practices that can help mothers to meet their goals with breastfeeding. It's also called the Baby Friendly Hospital Initiative and not the Breastfeeding Friendly Initiative, because we talk about the support of mothers, whether they're formula feeding or breastfeeding, throughout the 10 steps. So, in terms of how does this initiative fit with us in Canada, we are definitely reminded of the WHO Constitution that says that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. So when we think about our Canadian context, we may not be thinking about babies dying from not being breastfed, but we are definitely looking at morbidity, adulthood diseases which can be largely ameliorated and many of them prevented. And when we think about our aging population here in Canada, and we think about things like diabetes, heart disease, obesity, and many, many others that would come to mind, more breastfeeding, more exclusive and longer breastfeeding rates would definitely lower the incidence of those diseases according to the research. So thinking about whether or not BFI fits with our Canadian context, the Canadian Perinatal Health Report from 2003 says that breastfeeding is both primary food security and preventative health practice. And of course, it's foundational to the development of child health and family health for sure. When we look at the Health Canada documents, we see the Nutrition for Healthy Term Infants recommendations from birth to 6 months, which have a lot to say about the implementation of baby-friendly initiative and how it fits with the best practice guidelines that Health Canada set out. And it is reinforced again in Healthy Term Infants document from 6 months to 24 months, looking at 6 months exclusive breastfeeding and then the continuation of breastfeeding for 2 years and beyond with the introduction of appropriate complementary foods. So we're starting to see the 10 steps being mentioned in all our key documents in Canada. And when we look back at what mothers say, I like the slide from the Maternity Experiences Survey, although there's more up-to-date information, the statistics have stayed fairly stable. We're looking at a group of women that predominantly wish to breastfeed, so 90% initiation rate, and it drops quite rapidly towards the 6-month mark. What we're trying to do with Baby Friendly, it is a continuous quality improvement program that is using outcomes to see whether we're having an effect with our implementation of best practice. So we're looking carefully at those rates as we do BFI. We also bear in mind that the determinants of health are also the determinants of breastfeeding, and we see this when we look at our epidemiology studies. Income and social status, education, employment, social networks, the whole list of determinants of health are extremely important in terms of breastfeeding initiation, duration, and exclusivity. And when we look at our Health Canada statistics and we see the 4 main causes of illness in children, we can see that respiratory, diarrheal, atopic, and other infections remain at the top of the list of things that admit babies to hospital. And we also know from our evidence base today that most of these things can be reduced by increasing breastfeeding rates. So this is an initiative that definitely pays off, not only for individuals, but also for our provinces and our country in terms of costs for health care. And when we have a quick look at the reasons for decline in breastfeeding, they're very easy to pick out. Industrialization and employment practices, nuclear families no longer act as role models. We're having a change in our family structures, and definitely lack of support, social issues, cultural and societal biases for sure, make things difficult for women to meet their goals in many circumstances. So how does baby-friendly initiatives try to balance the scales for women? We look at the major initiatives that World Health has put in place, remembering that women are facing the same issues whether they are having their babies in Canada or in Timbuktu. We're looking at some basic principles that we know need to be in place. And one of those is, of course, the International Code, which is the marketing code that looks at ethical promotion of breast milk substitutes. That's been around since about 1981, and its subsequent resolutions. But, that was in place for many years before the global community realized that really having a code alone wasn't making a difference to mothers' abilities to breastfeed and continue breastfeeding. And that is why when they celebrated the Inocenti Declaration and the Rights of the Child in 1991, the Baby Friendly Hospital Initiative was launched to try to put in place practical measures that would make sure that women got off to a good start. And so you have a multi-pronged approach by WHO and UNICEF to increase breastfeeding rates globally. And since the Global Strategy for Infant and Young Child Feeding in 2002, you're starting to see the focus becoming very strong on supporting the formula-fed infant because they are identified as a high-risk group, with the evidence that we have to date showing that children are more at risk for certain illnesses when they are not breastfed, and we're identifying the formula-fed child as at risk. So looking at BFI then, we know that it is evidence-based. We are looking to see that best practices are carried out, so much so that in Canada, the accreditation standards body has had many years of dialogue with the Breastfeeding Committee for Canada, and ultimately now many of the 10 steps are included in the accreditation standards for hospitals in Canada. So this is a great coup for us and for Baby Friendly. We also know that BFI is outcomes orientated, and this is why it's attractive to ministries, because it is actually a measurable outcome. We have certain stages that facilities need to reach in order to show that they're meeting the criteria, and facilities are celebrated for every little bit of work that they do towards implementing best practice. So this is a very productive, positive journey that facilities go on when they become interested in implementing BFI. This is not the FBI, remember, it's the Baby Friendly initiative. So we are working towards supporting any small changes that happen. We're also looking to protect the artificially fed infant, as I said before, and we know that most of the tenets of the Baby Friendly initiative, the 10 steps, benefit all babies, not just the breastfeeding babies. So in terms of our guiding principles, as I've mentioned before a couple of times, informed decision-making is the key. Baby Friendly doesn't say that everyone has to breastfeed and that there will be no formula in sight. What it says is that families need to have all the information scientifically and non-judgmentally presented to them so that they can make the best decision for themselves and for their families, and then they're supported to do whatever they've decided to do. We also know that this is a very strong initiative for building the continuum of care. And when BFI is instigated, you see a need for different parts of the healthcare system to collaborate very closely in order to meet the criteria. So from prenatal education through the hospital situation and then on to what happens in the community, the net has to be tightened up really nicely and to include your peer support base. So you're seeing a multi-sectorial effort, and you're also seeing the involvement of communities with mother-family representation in terms of the peer support piece. When we think about working on BFI, basically we're looking at empowering families. We're empowering women to do what they need to do and to meet their own goals. And it is a really impressive public participation exercise as well, because we're trying to educate everybody, we're trying to change cultures, we're trying to make breastfeeding more acceptable for communities as a large. So in terms of our guiding assumptions, we want to see improved breastfeeding outcomes for mothers and babies, and we do that by measuring initiation, exclusivity rates, and duration rates. And there are other things that we measure along the way, and one of those very interesting things is that when we have babies who are being supplemented with formula, for instance, that those are being counted as well, because we are aware of the medical indications for supplementation. And when we look at our outcomes, we want to be sure that those medically indicated supplemented babies are added. In terms of best practice, they're actually added to our exclusivity rate, because we don't want, the fact that we're supplementing babies is not the problem at all. What Baby Friendly wants to know is that we're supporting women so that they don't get into a situation where babies need to be supplemented as far as possible. And that when that does happen, that there are medical reasons and support to help them solve their issues. The adequate practice outcomes is determined by the assessment, which is very much a process, a qualitative process, where we do interviews of staff, interviews of mothers, observation of the facility and of practice, and we look at the documentation that facilities provide to families. We look at the curricula for education of staff and prenatal education for parents. And when all of those things are brought together under the lens of the BFI, we make sure that they meet the 10 steps to successful breastfeeding, and we also make sure that they meet the criteria to show that they respect the code and that there's ethical practices involved around the purchasing of infant formula and the provision of formula when it's needed, with the correct teaching that needs to go with that. In terms of the most value that comes out of BFI, I would say that the process of changing attitude and practice is important, and not passing or failing this. This is not about preparing a beautiful window dressing so that when the assessors come, they can tick off their little check boxes and you make the grade or you don't make the grade. The value in this whole initiative is the journey of getting to the place where you invite the assessors in. And then, as Doris will speak about a little later, you're finding that value changes and morphs and beds itself into the culture of the facility. The further into the journey they go, the more unique their journey becomes, but the more integral it becomes to the ethical and cultural standards of that facility. It's a very interesting process, which Doris has got a very good example of. So in order to implement the Baby-Friendly Initiative, we know that the global tool has been around a long time. It has been revised several times. So the global tool consists of the 10 steps to successful breastfeeding and the WHO code guidelines. And when it came to Canada, in Canada we were the first country to devise outcome indicators for each of those 10 steps, because we found very quickly that the 10 steps as they stood, just simple 10 steps, did not explain to people implementing it exactly what was required of them. So it was Canada that devised the indicator document, so that there actually are no secrets about BFI. The whole assessment criteria are reflected in the indicator documents, and they guide facilities step by step with all points of approach illuminated, so that you don't need to worry about missing pieces out. If you use the indicator document, you will find your way. It's a very good blueprint, a map, if you like, to becoming in a position where your best practice outcomes will be guaranteed. So in terms of those the global criteria, the 10 steps, the practice outcome indicators, those are your guidelines, your self-evaluation tool, and they are available on the BCC website and the Ontario BFI and Ontario website too. And of course, then once you've reached a certain point where you think that you are fulfilling most of those requirements, the assessment process kicks in. But before that, you've got access to support just to help you find your way through the document if necessary. So the assessment process is a staged process, and I'm sure most of you are aware of it. First is the document review, and then there's a site visit where an assessor comes to have a look informally, but it's an extremely important stage, because we want to make sure that everything is in place so that when a facility moves forward for final assessment, that there is very little chance that they will not make the grade. The only thing that is not that you can't predict is what the mothers will tell us. And we have a random selection of mothers, as many mothers as we can talk to, and we interview them according to a set interview sheet, and that gives us our scoring for the maternal interviews. So the process itself is rigorous. We know that the staff and the clients find the process a positive one. We have never had any problems with the process in terms of people feeling unhappy with it, and it's working all over the world in the same way. And then once you have had your assessment, it's done by a team of assessors, and they report their findings according to the global tool to the BCC board, and it's the BCC board that grants designation to a facility, and that designation is valid for 5 years. And during those 5 years, work continues. You monitor to be sure that your statistics are staying where they need to be. You're improving practices. You're sorting out niggly little teething problems, and the staff become more and more comfortable with the practices that they're doing every day. So the 10 steps are very straightforward. I'm not going to speak at length on each of the slides, but I just want, for those of you that are not familiar, to know that the first step refers to policy. Facilities need to have a policy. It holds staff accountable for practice, and it assures the public that we have standards around care of mothers and babies and infant feeding. Step 2 is about education of staff, and it outlines what education is needed by different levels of staff, depending on how much direct care they give to women. But this staff includes everybody from your direct care nursing staff to your support services. And then Step 3 is about informing pregnant women about the value of breastfeeding and about the risks of not breastfeeding, and basically supporting their need for knowledge at the most appropriate time, which is when they are before they're pregnant and while they are pregnant. That's when they're looking for information. And then we're looking for adequate practice as determined by the assessment. This fits in perfectly here with the mother and staff training, because we're looking for positive attitudes. We're looking for practice standards that refer to best practice about skin to skin, early and often breastfeeding, basic skills like hand expression and no separation of mum and baby, good documentation, and referral into the community. We're also, of course, looking for the ethical pieces, the code being respected. So, when you look through these slides, you'll see a little bit more illumination of what the 10 steps are. For instance, mothers who are not able to breastfeed right away for maternal or baby reasons need to be supported to start as soon as possible. We need to be able to assess breastfeeding very efficiently before they leave hospital, because they spend such a short time there. We want to make sure that we're not sending people home that are not ready to go home. And then Step 6 is the one that Born is helping us with most, and that is looking at, breastfeeding exclusively and not providing unnecessary supplementation. We know about the medical reasons. We want good charting. We want good data going into Born so that we can see if we have a large amount of babies being supplemented for medical reasons. We are, through Born, able to look at, so what babies are these that need to be supplemented? Are they early babies? Are they late preterm infants? Is there a lot of C-section? Is there a lot of instrumental delivery? Are there any connections that are making us see this profile of heavy medical supplementation? It's a very fascinating approach that we can use through Born. And then we also look to see under exclusive breastfeeding, do we have information? Do we have access to donor milk from a human milk bank? Because if we're saying exclusivity is so important, we can't very well not have human milk for babies that are very much at risk. We need to be able to provide that option for those parents as well. When you look at the medical indications, there is a checklist in the 10 steps, which is reflected in Nutrition for Healthy Term Infants. And also we have the Academy of Breastfeeding Medicine clinical protocol number 3, talks about supplementary feedings in the healthy term neonate, and so on. We've got lots of good evidence for those indications. When we look at statistics, we are looking to see that hospitals and birthing centers are having 75% of babies exclusively breastfed on discharge from hospital. And when they enter the community, we're aiming for 75% babies still exclusively breastfeeding when they enter community service. And if they're not exclusively 75%, then we're looking to see that there's 75% any breastfeeding happening, and we're watching the trend to see that that exclusivity rate is going up over time. And that's why our data collection, consistent data collection, is so important, because we want to be able to recognize the improvements in practice. So Step 7 is about rooming in, it's about attachment, it's about empowering families to be able to do cue-based feeding, to understand their babies, to feel confident about going home with them and where to go when they've got problems. We don't want separation of mums and babies. Much of these 10 steps are about attachment theory, and they are so important. Not only, it doesn't matter what method of feeding your baby is having, it needs to be standard practice for all babies and mothers and fathers. And we also talk about no artificial teats, and we know that when we talk about exclusive breastfeeding, you really can't talk about exclusive breastfeeding if there's not enough breast milk. And so staying away from things that divert the sucking stimulus to the mother's brain are what Step 9 is about. It's really all about maximizing mother's ability to make milk, and not swaddling babies is one of the new pieces of evidence that's come to light as well. So artificial teeth, we have some really good research around why we don't want to introduce pacifiers too early. We just don't want to divert those suck stimuli away from the brain, as I said, but there's many other interesting research points to look at as well. In terms of step 10, the breastfeeding support that needs to be in place for women is not only professional support. The research tells us that the most important piece of the puzzle in order to keep mothers breastfeeding exclusively and for a long time to meet their goals is that of peer support. Mother-to-mother support groups are so important. And how facilities like hospitals and public health manage to incorporate peer support into the continuum of care is the hardest of the 10 steps, I think, to achieve. Because in the past we haven't really taken too much notice of the value of peer support through when we look at breastfeeding women. And we see it in other things like, smoking cessation and depression support groups and so on. But we need to utilize the outstanding value of peer support and put it in place for new mothers and babies as well. So step 10 is fascinating and difficult sometimes to do, and yet being done with great success. The more we learn to respect that the strength of women outside of the professional field, the easier our job becomes as professionals. So there's a little more information there about community support and peer support. And then the last step there that we need to think about is that all babies benefit if the WHO code is being respected. It is a way to protect infants from unethical marketing. No health claims are allowed according to the Food and Drugs Act of Canada, and there's no conflict of interest for staff. When you look at Nutrition for Healthy Term Infants document, you will see that it says there, some infants may not be exclusively breastfed for personal, medical, or social reasons, and their families need support to optimize the infant's nutritional well-being. And in that chapter, they speak about the international code and its value. We also know the Codex Alimentarius, which is a global group, demands adequate labeling of products, and Food and Drugs Act of Canada monitors the standards and disallows health claims. So from many different perspectives, we have some recognition of how important the ethical piece is, and for baby friendly, the code is just one piece of many other pieces that need to be in place. So for your interest, if you look at the indicator document, you will see that there is an Appendix 2.3 which talks about how we should support non-breastfeeding mothers. And we need to talk to them about cue-based feeding, responsive feeding, and all of those things too. And there's a couple of slides in there just to make you aware of some of the fun that we have when we do assessments. It's a really incredible journey. Tools that can help on the way is the evidence for the 10 steps has been lately published, and that is an updated collection of evidences for each of those 10 steps. We also have the mother-baby dyad care, which has been produced here in Ontario, which is very important because it really does put a lot of emphasis on skin-to-skin. And skin-to-skin is the precursor for good feeding behavior. So it needs to happen for all babies, whether they're being breastfed or not. And then if you're interested, online you can get the Baby Friendly Initiative in Canada status report for 2014, and that breaks down the 10 steps or the best practice principles province by province. And what we need to remember is that it is really the stages of change that is the purpose of all of this. Things that we've seen in Ontario: increased provincial territorial ministry awareness and involvement in BFI, increased information sharing and collaboration, and of course increased efforts towards consistent infant feeding surveillance methods. And I think that's one of the greatest things that's happened out of BFI with the help of great programs like BORN, is that we're starting to see some consistency in data collection, which we did not. We had a really hard time comparing apples to oranges before. And then the evolution of understanding of the inclusiveness of BFI is something that we're starting to see as we go back and do reassessments. We're starting to see the depth of understanding becoming evident in these facilities. And then there's also a parallel phenomenon that's happening with the increased appreciation for the use of donor milk. This slide is hard to see, but I put it in there because it just gives you some idea of how the web is in terms of the structure of BFI from the global perspective to the Canadian perspective, and then how we deal with implementation of baby-friendly throughout Ontario is the last piece there. And if you have more questions, please contact me. We'll be happy to talk you through that. I don't want to spend too much time on that now. So BFI outcomes in Ontario, I've used up my time, but this is the last slide that I'll speak to. What's happened for us in Ontario is that we very soon identified the need for consistent data collection, and there's been immense collaboration to create a standard system, as standard as we can make it, and you know more about that than I do. I'm just on the receiving end, but we are eternally grateful that we're starting to see something come out of that. We also have the accreditation process, including BFI tenants. We're seeing more collaboration with Health Canada on the Nutrition for Healthy Term Infants documents. We've had collaboration with PHAC on the Family-Centered Maternity and Newborn Care National Guidelines, which will be out in the next year or two, and that's showing many improvements, especially in terms of the 10 steps. We've collaborated with RNAO's best practice guidelines. Many interest groups have done work. The BFI is a benchmark for public health standards now, and we have a provincial BFI strategy for hospitals led by the ministry as well, as you all know. Community of practice groups have been established, so there's one for hospital and there's one for public health. And we have increasing community supports in place for peer support and other kinds of support, many more breastfeeding clinics, telehealth style breastfeeding helpline, and we also have increasing numbers of baby-friendly designations with increasing breastfeeding rates, initiation, exclusivity, and duration wherever we have an implementation of BFI in progress. So the future means we're going to look at including some mother-friendly practices in the next revision of the indicators and expanding the BFI into the NICU. And so step by step, day by day, we keep on going. And at that point, I will hand that over to Doris.
Thank you very much, Kathy. That was a great presentation and lots of good information there. And I want to welcome Doris to our webinar as well. And Doris Balcaris is a registered nurse, and in 1996 she also became an international board-certified lactation consultant. And Doris is involved in developing and providing BFI and breastfeeding education for physician, staff, and midwives at Grand River Hospital in Kitchener, as Kathy mentioned earlier. And she was the BFI project lead prior to Grand River achieving their baby-friendly designation in 2008. And she again led the team through their assessment in 2013. So she's got lots of great experience. And she's also involved in the Childbirth Quality Council and co-led the BFI Ontario Hospital Network Group. So thank you very much to Kathy, and now we'll welcome Doris to share some of her insights with us.
Thank you very much. I'm not sure if my slides are going to work here, so we'll give it a shot. Our computer's a little bit wonky, and no, I don't think they're moving on, so I'll just get you to move my next slide. Thank you. Thought I'd just share a little background about Grand River Hospital. We are the only hospital in our area that provides obstetrical care. Last year, Grand River had over 4,100 births. Of those, 3,662 were healthy term newborns that were greater than 37 weeks gestation. Our obstetrical unit is a 41-bed unit. We have 24 LBRPs and 17 postpartum antenatal beds. Our breastfeeding initiation rate is about 92%, and of that, 75% are exclusive breastfeeding. If you add into that the medically supplemented medically indicated supplementation, our breastfeeding rate is about 81%. Next slide, please. We received our initial BFI designation in 2008, and we redesignated again in 2013. Next slide. Our journey started about 10 years before we became BFI designated. Recognizing that BFI protects, promotes, and supports breastfeeding, a small group of our lactation consultants formed a breastfeeding committee to start working towards this initiative. About 5 years later, I joined the team of LCs. Some of the steps were already in process. So we developed a breastfeeding policy, and we were starting to promote skin-to-skin care. We had 24-hour rooming in because we had gone to an LBRP model, and we were encouraging a support person to stay with our moms that had vaginal births, but we weren't doing that so much for the C-sections. We were defining and monitoring medical indications for formula supplementation, and we were starting to get some informed consent officially. Several times a year, we invited Kathy Venter to come and teach our 18-hour breastfeeding course. The nurses were encouraged to participate, and the hospital supported this by paying for the course. With her passion and practical approach, Kathy significantly impacted the nursing staff. She inspired them to start looking at their practices and the effect it had on breastfeeding, and I would say that her influence significantly impacted our successful designation. Next slide. One of the roadblocks that was repeatedly brought up was the purchasing of formula and breastfeeding supplies, and I hear this from hospitals many times. At the time, we had a director in our childbirth program who strongly supported the vision and the values of BFI best practice standards, and she approached the hospital board to ask for additional money. Through her effective presentation, the board approved the purchase of formula and gave their support for the hospital to work towards the BFI designation. And I would say this was a very significant turning point for us. And for those of you that are not yet purchasing your formula, BFI Ontario has put together a document entitled Business Case for Baby-Friendly Initiative to help you with that part of the journey. And I really encourage you to look that up on the BFIO website and download the document. It's an excellent document and very helpful. Next slide. From that point on, the decision had been made, and we started moving fairly quickly. We were no longer saying, can we do it? Instead, we were saying, we are doing it. It took about another 3 years of very intentional work, lots of education, practice changes, and a lot of perseverance. We formed a new committee with all the stakeholders at the table. As the BFI lead, I used the BCC Integrated 10 Steps Practice Outcome Indicator document that Kathy had mentioned earlier as my ongoing guide to what we needed to focus on and achieve. And it really was kind of the right-hand man in the whole thing. We just kept following that and using that as our guide. Since BFI is a hospital-wide designation, connecting with other areas of the hospital was really exciting as we engaged them to be part of the journey with us. The retail pharmacy put only baby-friendly items on the shelf. Our gift shop stopped selling anything that had pictures of soothers or bottles. The surgical floor adopted a policy allowing mothers to keep their babies with them if they were having surgery. And we created a nice place for pumping for hospital staff that were returning to work after their maternity leave. It's amazing what we had accomplished when everybody worked together. We finally received our pre-assessment, and then about 6 months later, we had our final assessment, and we were designated baby-friendly in 2008. Next slide. In 2013, we redesignated, and our journey continues. One of the assessors commented that in 2008, we did a good job in meeting the requirements for BFI. However, this time around, it's evident that BFI has become the culture of the hospital. It is what we do. It's who we are, what is expected throughout GRH. Breastfeeding is not only best practice, it's normal. We are very pleased with our achievements, but recognize that the journey is not complete. It's an ongoing journey of always wanting to be better, to do more, and to promote best practice in every aspect of care. So we continue to grow, and we look for creative ways to not only maintain, but to excel. Next slide. I thought I would just highlight a few of the positive things that happen through our BFI designation in each of the 10 steps. It's a hospital-wide support for breastfeeding. So we have stickers throughout our hospital that encourage mothers to breastfeed anytime, anywhere. Actually, our hospital breastfeeding policy is part of the hospital-wide orientation when anybody begins work at our hospital. So it's just the norm. It's what we do. The staff is expected to update their breastfeeding education every 3 years to stay current. Our hospital website has excellent links for parents to learn and make informed choices during the pregnancy and after birth. Skin-to-skin care is the norm after birth. Newborn blood work is done at the breast. NLC facilitates a breastfeeding group session twice a day for all mothers to come together to talk about their breastfeeding experience, to share ideas, explore solutions, and understand that breastfeeding takes time to learn for everyone. Increased exclusive breastfeeding rates and decreased formula use and general formula use in general. Parents are making informed choices when formula supplementation occurs. We have 24-hour room-to-room. 24-hour rooming in. And that's just normal. The mother and baby dyad are not separated. Partners are encouraged to stay and give support no matter how the mother delivered or whatever method she is choosing to feed. Mothers are taught about hand expression and cue-led feeding. Alternative feeding methods like cup feeding, spoon feeding, or lactates are used when formula is required to best support the ultimate goal to get back to exclusive breastfeeding. Bottles are a last option. And we encourage mothers to link to the community resources after discharge for ongoing support. Next slide. There are ongoing challenges. Education is costly. Physician, midwife, nursing education is ongoing. It's challenging to find the resources and the time to ensure that everyone maintains current education. We're always looking for creative ways to support the staff and instill the confidence to do a job well. BFI requires a less than 10% formula supplementation for non-medical reasons, and it's an ongoing struggle to support the staff, educate patients, and confront cultural beliefs to not supplement unless there is a medical indication. Using Born has been really helpful in tracking the supplementation rate and assessing reasons for supplementation and looking at trends. One of the things that we were able to determine through Born was that there was a high non-medical supplementation rate among primate C-sections. And so this has given us the opportunity to start targeting that population to see how can we better support them to reduce this unnecessary and potentially harmful practice. Compliance is an ongoing issue. There's lots of reasons why. There's heavy workloads, lack of time, lack of confidence, cultural pressures and beliefs, just to name a few. Nurses are busy with their heavy workloads or may not have enough confidence with breastfeeding. Our lab techs are called to another department, so they don't want to wait to put the baby onto the breast for the blood work. Or patients have family members giving them conflicting information. There's also many influences that cause the patient to get mixed messages. Consistency is challenging, so that's many factors that influence their feeding choices. So how do we best approach the ongoing journey of BFI? Next slide. Whether you've achieved your designation or are working on one of the steps, I would suggest, in summary, this very simple acronym. START, START. S, share the vision and stay focused. State clearly what you want to do and why. We need to clearly know the direction we are going and why it's important. T, talk it up. Teach patients, staff, physicians, and midwives. Be creative in the methods of communication. Our breastfeeding group sessions that we offer twice a day help to connect with patients, talk about the basics of information, and facilitate consistent messaging. A, anticipate opposition and welcome it. As long as people are asking questions and challenging you, you have an opportunity to teach them, explore their issues. There may be some value in them and the problems that they are finding, and come up with solutions. Don't shy away from the naysayers. Embrace them and show them that this really is the best. R, review, repeat, and remind everyone frequently of what you want to achieve and what the benefits are for everyone involved. Nurses have less workload if babies latch better because they were left skin to skin. Parents are more confident. Babies feed better. There's less cost to the family, less cost to the hospital when the community is healthier, just to name a few of them. T, take time to celebrate the successes. Find creative ways to acknowledge and show appreciation for a job well done. We all love to hear, thank you, you did a great job. Just in summary, I've really found that talking to people who have been on the journey before and have really helped to encourage me and obtain very valuable information. People who are willing to honestly share their successes and their failures. They know the roads. Some of the roads will be the same and some will be different. But all of the roads are learning opportunities. Next slide. So this is your unique journey. My encouragement is to START. Start the journey and enjoy the ride. Thank you.
Thank you so much, Doris. That's awesome. And what I really noticed out of both Kathy's presentation and yours is I love the word journey and the values in the journey and enjoying the ride. Good advice for sure. So what we'll do is open the chat box. It's been open. If any of the attendees have any questions, just type them into the chat box and we'll be happy to answer them for you. Some excellent expertise here. And I just wanted to also mention that Sandy Dunn, our Born Knowledge Translation Specialist that represents Born on the BFI Strategy Implementation Committee and is working closely with this breastfeeding expert panel to obtain feedback about Born future database elements in Born and report revisions that may be needed to help with your surveillance of BFI. So we have a question in the chat box. It's a question for Doris. It says, how did the health unit get involved in the BFI certification process?
They were part of our committee, and we recognize that we really need to link with them because when people leave here, that's their next support system. And so we had them part of our initial committee right from the start, and we had them involved in giving us suggestions as to, community perspectives. We also had a mom from the community on our task force, and her input was really very valuable as well. So right from the start, we had them as part of our assessment committee and our BFI committee.
That's great. Another question for you, Doris. It says, I'd be interested in knowing the size of the lactation consultant team at Grand River. What is the optimal lactation consultant to birth ratio? And much of the BFI work seems to be led by lactation consultant teams in the hospital.
Well, you're absolutely right about that. The LCs certainly were the lead at our hospital. We have a 12-hour LC that works 8 to 8 every day, and we are very grateful for that. So we work with the moms, babes, the nursing staff on the floor. Those are for our inpatient. And then we also have an 8-hour LC that works from 8 to 4 Monday to Friday. And we also have an LC that works in our Billy clinic doing the blood work. So all of our blood work that is done as an outpatient is done with the baby at the breast, or we use sucrose for the babies that are being, and they're held skin to skin for the moms that are formula feeding their babies. So again, we really try to do the best practice in all of those areas. We have early discharge. We have 6 to 24-hour discharge for our vaginal birth, so we do a lot of our newborn screening in the outpatient clinic, and that's done by an LC. We have 8 LCs at our hospital.
Right, and you mentioned that there's about 4,000 births, correct?
Yes, yeah, 4,200.
Right, big site.
Mm-hmm.
There's a question here for us at Born. Sorry, it's just jumping. I'll go back a little bit. It says, does the Born database track tongue tie rates and tongue tie releases? And that is not something that is tracked in Born. Another question here. How have health units achieved, jumping on me again, sorry. How have health units achieved a 3-hour clinic component? I don't know, Doris, if you would know or Kathy would have any advice on that.
It's Kathy. They achieve this in many ways. There's mentoring opportunities if they've got a breastfeeding champion. There are opportunities to work with hospitals that have breastfeeding clinics, and they go along as observers there. And remember, something really important is that baby-friendly succeeds not because of LCs, but with LCs you do not, it's nice to have champions, but they don't need to have to be LCs. So just I just wanted to put that little piece in there. It's different ways to get your clinical experience. Just depends on what's available to you.
Thank you, Kathy. Here's another one I think, Kathy, you might be able to shed some light on. It says, did you look at estimated blood loss and research on decreased breastfeeding rates for mothers who had C-sections? And she's wondering if women who've experienced significant postpartum hemorrhage have less milk production.
There are some clinical writings that is one of the risk factors, but we also know that skin to skin can help to modify those risk factors. So what we do is, it doesn't matter you don't know when you have a patient in front of you whether her risk factors are going to affect her milk supply or not, because they're multifactorial and a lot depends on the mother's individual coping skills herself. So we're looking at BFI as being there to ameliorate a lot of issues. We take each individual situation as it comes. And yes, indeed, when we look into the literature that supports best breastfeeding outcomes, you do see many different things that can affect milk supply. But we do know that BFI puts in place many things that can ameliorate. So skin-to-skin, hand expression, early, often, and effective breastfeeding, careful assessment to make sure that babies are actually transferring milk, and the follow-up into the community to make sure that, day 2, day 3, when babies start getting into trouble if they're not transferring milk, that there is somebody who will pick up that phone and speak to the mother, or that the mother has the knowledge of where she can call to get help if she's worried. And this is what BFI is all about. Major blood loss is one of many, many things that could impact on the mother's successful breastfeeding. So we try with BFI to put in place steps that will catch people no matter what the issue is.
Thank you, Kathy. Another question here. What can be done or is being done to advance breastfeeding knowledge and support for mothers and families in the physician's offices or a walk-in clinic?
It's Kathy again. Well, when we do implementation of BFI in the community, public health is really good about giving breastfeeding messaging, health messaging in terms of population health. And so many examples exist of where public health has taken on itself an outreach to physicians in the community. They do that in many different ways. There are, mailing lists. There are e-alert bulletins that go out to physicians about breastfeeding and infant feeding generally. So really and truly, when we say that BFI is a continuum of care issue, it really does go down through the line. But it needs to be something that the individual, health region, public health, combining its efforts with hospital, combining its efforts with champions in the community, need to work on this outreach together. It's not something that BFI says thou shalt do this and this is how you shall do it, because every region is a little bit different. All their physicians are, needed maybe a little bit of a different approach. So it's about building connections and seeing what messages we can bring to have that change happen. We want collaboration. We don't want them to feel as though they're having the law laid down. It's a process of growth, not one of forcing things. I hope that helps a little bit.
Thank you, Kathy.
May I just, before you move on there, if you are on the calls with the public health, we have the Ontario, the BFI Ontario has one group which supports public health units to do their work, and they will be very happy to share their strategies on how they approach the physicians in their communities.
Thank you. One question here. How could Born track the use of alternatives or complementary medicines or herbals? I would suspect that means to assist with breastfeeding or milk production. So at the moment, Born does not collect that information, but every request that comes to Born, we review for future enhancements. So I'll make note of that, and that'll go through the proper channels at Born as we do for all suggested added database elements. So thank you for that. I don't see any other questions in the chat box at the moment. We'll just give it a few minutes. Our timing is quite good because it's just a few minutes to 1. There's another question here, but I just see kind of half of it. It says, Kathy touched a point on supplementation during the first days when milk doesn't come in. If a mother goes back to exclusive breastfeeding after, how would that be counted? So I think that's a question on how that's counted in the BIS, the Born Information System. Prior to April 7th, in the Born Information System, we were capturing breastfeeding rates at discharge, and as of April 7th, it's now from birth to discharge. So it would be counted in the BIS as supplementation from birth to discharge. I hope that answers your question. Okay,
it's
great.
Kathy. Can I chip?
Yes, please.
Sorry, just to say that's sometimes why when we do BFI, the statistics look really interesting, because you have discharge from hospital rates saying X, and then you may have a week or two later when public health collects data showing an increase in exclusivity, because it depends. You can never be exclusive if you've ever had formula, but the way that some questions are asked is, what has your baby eaten or drunk in the last 7 days? And that will sometimes, the further in you get to the age of the baby, that sometimes helps you to recoup some of those issues, those babies where breastfeeding has been rescued, if you want to put it that way. And that helps us to reflect the best practices when you see that in the community. But it really is difficult, because you are not exclusive for research purposes if you have ever had anything other than breast milk. And yet the way WHO and the BCC collect that question, we are in the last 7 days, what has your baby had to eat or drink? Mm-hmm. So that's where it gets tricky. And thank goodness we have Born, because then we can untangle the weave to figure it out.
I was just going to say the same thing, Kathy, in that Born tells a story. And so if there has been breast milk substitute, also in Born there's a data element that says the reason for the breast milk substitute, including infant medical or maternal medical reasons. So you're right. I think it tells a story, and you are able to untangle the reasons. Good question. So we're almost, I don't see any other questions in the chat box, and we're almost out of time. And I'd really like to thank Kathy and Doris for an excellent presentation, and to thank you for helping us understand BFI implementation in Ontario and how it fits with other provincial and national strategies, and sharing with us the BFI journey at the Grand River Hospital. So thank you very, very much to both of you. 2 quick announcements. Our first slide today was the Born conference, and just a reminder that Born is hosting a 2-day conference, the right information in the right hands at the right time, using data to improve maternal child care and outcomes, and it will be February 6th and 7th, 2015 at the Fairmount Chateau Laurier in Ottawa. Call for abstracts is now open, and the Conference Program Planning Committee invites you to submit an abstract for presentation, and the deadline for that submission is September the 12th. So please visit our conference website for more information, again at the Born Ontario website, www.bornontario.ca. I'd also like to tell you that we're taking a break from the Born Provincial Rounds over the summer months of July and August, but we will be returning in the fall, and you'll receive notification of those rounds once they're planned. So thank you once again to our presenters, and thank you for all your attention, and we look forward to having you back in the fall. Bye for now.